Hello, this is Black Women's Health Across the Lifespan, a three-part collaborative learning series. Today, this is our last session. It's been such a great session and series, collaborative learning series. It's been so wonderful. This is promoting health and wellness for Black older women. This is through the F.E. Berry Training Institute, and our training today is funded by the Department of Health, HOSTA. Our learning objectives, these learning objectives are for the entire series. We're going to discuss the unique perspectives of health inequalities on the lives of Black youth, young adult, middle, and older age Black women. Describe the common socioeconomic determinants associated with lack of access to health care and vulnerability to intimate partner violence in Black women of reproductive age. We talked a lot about that yesterday. We will list the health inequities that drive disparate rates of HIV and STIs among Black women across the life course. Describe the comorbidities in older Black women who are experiencing or have experienced menopause. We will hear a lot about that today from our panel experts. Detail the healthcare access barriers and provider bias and stigmas, and analyze the factors that foster resilience in our Black women across the lifespan. You guys are in for a treat today. We have a great session, PowerPoint, and panel. My name is Lisa Frederick, and I would love to introduce Hannah Tesma, who is the co-moderator. And Hannah is a lecturer at George Washington University, Milken Institute School of Public Health. Hannah Tesma is a public health practitioner with 14 years of experience in managing national capacity building, training, and technical assistance programs on HIV/AIDS, prevention, care, and treatment. She has worked with communities at increased risk for HIV throughout the US and globally. She is a doctoral candidate in public health, health behavior at the GW Milken Institute School of Public Health. Hannah holds a global master's in public health and epidemiology from NYU and master's in social policy and program evaluation from the University of Michigan. Hannah is currently conducting research on PrEP and contraception uptake among Black women here in DC and teaching a social and behavioral health course on designing evidence-based interventions to MPH students at GW.
Thank you, Lisa. And let me go ahead and introduce Lisa, my co-moderator. Lisa works at Help HIV as a capacity building manager. She provides capacity building services on organizational sustainability, programmatic infrastructure, as well as systems development. She's devoted 20 years working in the field of HIV/AIDS, viral hepatitis, and sexual health. Lisa has experience providing HIV TA and capacity building, leading Elton John and Elizabeth Taylor funded national HIV technical assistance and capacity building programs throughout the Southern US, working to improve health outcomes for Black and Brown communities. Lisa has also led the development and implementation of a New York City Department of Health and Mental Hygiene, Health Literacy, HIV, and Older Adult Sexual Health Community Initiative, providing HIV testing and HIV sexual health messaging. Her expertise extends to translational educational research programs, which resulted in the development of an HIV and older women's program focusing on issues of intimate partner violence, menopause, sexual health, and resilience. Thank you, Lisa.
Thank you, Hannah. I just want to say these 3 days have been great moderating with you. Hannah has been a friend and colleague for many years, and we just enjoy working together. And I think that this is going to be the last of a great three-part series. So thank you, Hannah, in advance.
This is the grand finale.
Grand finale. So this course has CME CE accreditations provided to you jointly by Postgraduate Institutes for Medicine and Health HIV. There are no disclosures from any of the panelists or Hannah or myself. Guys, you should have received a CME CE handout on how to claim your credits. We are encouraging everyone to complete the evaluation that is sent whether you are claiming credits or not. And this slide just gives some instructions on how to claim those credits that you have already received or will receive shortly. These are the type of credits that we are providing for each day of our three-part session, three-part series. So again, welcome everybody. We are so excited. This wraps up our 3-day collaborative, 3-part collaborative session. And I just want to give you guys a quick background on how the series came to be. And it was just, as the slide states, a reflection of the times. COVID-19, racial justice movements, Black Lives Matters movements. We just really wanted to do something substantive. And we really wanted to create a platform that was solely related to Black women and all the complexities around health and culture, strength and vulnerabilities throughout the lifespan. So we are just excited that we got such a great response. We have received so many great messages and love from everybody that registered and commented. So we appreciate that. Hannah, please add to that if you like.
Well, yeah, we're happy to have people returning back, and we're excited to venture onto this particular topic. And this is something that we have, the entire panel that's here today has been working significantly on older adults' work. So we're really excited about this one. We're happy you came back, and hopefully you will find this as informative as the previous
yes.
one. So thank you. All right, so I think the first slide here is a polling question, I believe. Yes, okay. So we are going to pose a couple of polling questions throughout. So the first polling question will come up shortly. And it's about your viewpoint here. So the first question is, at what age do you consider someone to be an older adult? Do you consider an older adult to be 50 and up, 60 and up, 65 and up, or 70 and up?
This will be interesting to see, Hannah.
Yeah, this is something that always comes up. We did, over 10 years of trainings on HIV in older adults, and this was, the topic that always created some controversy. So it will be interesting.
And it differs sometimes between regions of the country, between communities, culture. So this is interesting.
Mm-hmm. And don't mind that you saw the slide from before that just popped up. Just ignore that. Let's act like that didn't happen. Oh, and some people are chatting also. Okay, I see someone saying 40 and up. Okay, that's not even an option on here.
40, oh wow.
If you haven't yet answered, please select one of the bubbles. Someone said 40. If we had to choose 50 and up, 60 and up, 65 and up, or 70 and up, 40, OMG. Okay, sorry.
Really apologize to everyone.
Okay. Oh my goodness, that's funny. Okay, so let's see. So it looks like most people are saying, well, actually it's really close, either 50 and up or 60 and up. And so I know I've been known to ask trick questions over these past couple of days, and this isn't really a trick question. It's just that there's no real standardized right answer here. It really depends on who you ask, because, I mean, look at this group alone. We can see that there's some variance here in the responses, but it depends. If you ask the UN, they might say that it's 60 and up. If you ask the World Health Organization, they'll say 65. If you look at Medicare, it's also 65. If you look at the Older Americans Act, it's 60 and up. Or if you look at CDC, they say 50 and up. So it's really difficult for us to characterize this group and come up with an age range that everyone will agree with. And so we really wanted to put that out there right at the forefront and say, there's no correct answer here. And it's really sort of arbitrary the way that they select these numbers. I will say that CDC, as it relates to HIV, saw that adults living with HIV in their 50s were presenting with diseases much earlier in life than what was expected. And so people in their 50s with HIV were presenting with comorbidities that people would usually not see until they were in their 70s. And so there was a lot of discussion about either accelerated aging due to HIV among older adults or accentuated aging. And so that discussion is out there, and there's a lot of literature there that we can kind of look at. But I just really wanted to say that we don't have one correct answer, and lots of different things can be considered an older adult depending on who you talk to. Right. And someone here, William Blakely, is saying it depends upon how you feel. And someone else saying, I think the age relates to the activity in mind, unless you're asking as it relates to the census. Okay, now there's another whole thing to consider. So I think you get the point here that it really depends who you ask and the context in which we're having a conversation. So, okay. All right. So I will say that when we look at this group, I also wanted to say that when we say older, for the purposes of this roundtable discussion, that we want to consider that we're saying older than the group we were talking about yesterday. And the group that we talked about yesterday is older than the adolescent group we were talking about prior. So this group, older adult, mature adult, senior, there are many different words out there that are used to describe a group that's older than 45 or older than 50. So developmental considerations, here are some things that we, and you'll notice those of you who have been here with us the past couple of days that we're using the same sorts of ways to frame this discussion. So we look at human development and what the developmental considerations are. We looked at some of the psych scholars, Havighurst and Erickson, that sort of defined what these things look like. And they may be different for each person. Culture may play a role, and maybe it's not as linear as we expect it to be, but we wanted to create some sort of broad framework to start with, and we can, sort of define that more as we go along, and we'll bring our panelists in to discuss that more too. So all that being said, developmental considerations, you're adjusting to retirement, adjusting to physiological changes, meeting social and civil obligations, possibly adjusting to loss of a partner or spouse within this age range. And notice 50 and up is the biggest age range as compared to the rest of the others that we talked about the last few days. All right, I'm trying to move forward, but I can't. Okay, there we go. All right, so older adulthood. Development is continuous throughout a person's entire lifespan, occurring in stages. Those are a bit liquid. They're not as linear as we expect them to be. A person moves from one stage to the next by ideally successfully resolving developmental tasks from before. So the successful transition from adulthood to older adulthood is a time for reflection on life accomplishments. At this stage, people want to feel a sense of fulfillment and want to contribute to the development of others for the purpose of future generations. And that could be through raising children, that could be through advocacy, through mentorship, and maybe through other activities as well, whatever one person chooses. So engaging in meaningful and productive work is really important within this stage of life in a way that contributes positively to society. And that can be in so many different ways, of course. Okay. Oops. All right, so that last bullet there was, we could go back to that, moderator. Can we go back? Okay, there we are. Almost. Okay, so life failures may lead to regret or bitterness, and that's something that could exist within this group. Is that relevant to everyone? No, but it's something that could happen if someone feels that maybe they hadn't fulfilled things that they wish they had fulfilled by this point in life. And these sort of questions about what could have been, or what would have been, or what should have been, could exist also within this age group. Okay, now we're ready. All right, so some of those changes are listed here again: the retirement, physiological changes, menopause is a big one, which we're going to talk about quite significantly today. Managing beauty and aging is another one that has come up quite a lot in the trainings that we've done over the years. What does that look like? Those changes, that happen with life. Whether the loss of a spouse or partner is through widowhood or through divorce within this stage of life. Creating and maintaining social support networks is really, really, really important. There was a study that came out in 2005 or 2006 at this point, research on older adults with HIV, that found that the biggest threats to quality of life for older adults living with HIV was social isolation, depression, and loneliness. And so Black women are not exempt from these threats to quality of life either. And so we wanted to mention those as well here. Okay, so our second polling question came up quick, so let's go to that. So polling question number 2 is about menopause. So Black women tend to reach menopause at the same age as women of other races. Is that true or false? Do Black women reach menopause at the same age as women of other races? If you hadn't clicked the button, please go ahead and do that. See a couple in the comments here. I see someone saying older, elderly tends to have a negative context, which it should not. Media and other cultural influences play a part in people's perception of aging. Absolutely. Okay, We'll give you a couple more seconds and then we'll wrap up the poll. All right, so let's see what people said. False. Okay. So overwhelmingly, 66% are saying false. And that is correct. Black women don't reach menopause at the same age as women of other races. And we'll talk a little bit about that on the next slide. As it comes up. Okay. So first, to define menopause, for those of us that are unfamiliar, menopause is defined as having 12 consecutive months without menstruation. Next, please. Okay, the phases of menopause can vary widely among women, and perimenopause is really that transition that happens until you get to menopause, where those 12 consecutive months happen. Okay, now I think I can control my screen. Let's see. No? Okay. Sorry about these tech issues here. Okay, so research from the Study of Women's Health Across the Nation, or SWAN, shows that Black women reach menopause 2 years earlier than the national median at age 49. Black women tend to begin perimenopause, which I was just speaking about a second ago, a bit earlier, experience more intense effects due to this process, and have a longer transition period from perimenopause to menopause than white women. And that can have a lot of long-term effects, which we are going to discuss here. So why do some of these health disparities exist in terms of menopause occurring earlier or perimenopause being a longer period of time? And we have a quote here from Dr. Nanette Santoro from the University of Colorado School of Medicine and Obstetrics and Gynecology. And she's saying here that a lot of the differences have their basis in lifestyle, SES, and other stressors such as systemic racism and their long-term consequences. And you'll remember we have spoken quite a bit about what these stressors look like, about allostatic load, and we talked about the weathering and all of those things that live within our bodies and how stress creates inflammation and can impact one's life for the long term, particularly for Black women as a result of systemic racism. So the stress that's there damages the cardiovascular system, it disrupts digestion, it sparks inflammation, and we know that as we age, there's also something called immunosenescence, which is the aging of the immune system as we age. So it just, the function declines naturally as we age. Allostatic load that we talked about on the day of adolescence and we talked about yesterday with reproductive age is an accumulation of stress over time. So as we go along in life, those things stay within our body and they accumulate over time. So that's something that contributes to some of these higher risks for disease and lower resilience due to illness when it does happen within this group. Can you put your question in the Q&A box? Yes, you can. And please feel free to do that. So when we get to Q&A, you can go ahead and do that. So allostatic load is accumulative, like I mentioned. It increased during midlife and older adulthood. There was a 2018 study that came out and found that higher allostatic load among Black women was there as compared to white women of the same age. And that was due to race. That was controlling for all these other factors like STIs, and poverty and other issues, education. Okay. So remember, we were saying that perimenopause may be longer with Black women, and that can be problematic because that can increase risk for many diseases, and that's a long list of them. So the timing of menopause is linked with risk for heart disease, for stroke, osteoporosis, bone fracture, and overall life expectancy. We know that bone density declines as we age as well. Later and shorter perimenopause improves outcomes for all of those, but Black women are experiencing earlier and longer perimenopause. So we see why that might be an issue and create health disparities within this group. Okay, so we see this, this picture here. And this was developed by CREA, I would say, which used to be the AIDS Community Research Initiative of America, based in New York City. And Lisa and I were part of a team developing this campaign here. And it was part of a campaign called Age is Not a Condom. And sometimes people don't understand, but what it really means is that just because you're of a certain age doesn't mean you're not at risk for sexual, you're not at sexual risk. There are a lot of ideas out here that people, you know, within a certain age group or older women are not having sex, and that's completely inaccurate, and it's a major issue within our society. If we could go to the next few bullets.
Yeah, and I just want to add with that, I remember when we put these up in bus shelters throughout New York City, through Harlem, through Chelsea, Brooklyn, Bronx, Queens. And what we did was we would actually watch people's reactions to these ads, you know, and, you know, it was really amazing that in our Black communities, we got more pushback in our Black communities with these ads than in other communities, you know, so what implications that have on, you know, some of the things that we're talking about today. So it did take a while for these ads to actually get some traction and for communities to actually embrace the message of women who are 15 older being sexually active. So that was very interesting.
Absolutely. Okay. So if we could go to the next. All right, there we go. Okay, so something really important here is that there are a lot of missed opportunities for discussion around HIV and STI prevention within this age group. And so there was a study that came out showing that approximately 22% of older women report discussing sex with their healthcare providers. There's this strange thing where maybe a clinical provider might be younger than their patient or their client, and they might feel like, oh, it's like talking to my mother, it's like talking to my grandmother about sex, and I don't want to bring it up. If they don't bring it up, I won't bring it up. And so there's a missed opportunity. Yeah. Providers have to recognize and respond when older women engage in sexual risk behaviors, and they have to know what questions to ask and to be able to overcome that strange barrier that exists there. That's something that is creating more issues within this population when you're not able to have these sort of discussions, and that makes Black older women at significantly greater risk. So many women experience, this is another piece here about some of those psychosocial issues, many women experience a decline in self-esteem as they age and may have more negative views of themselves due to a perceived loss of sex appeal over time, in dating and in their sex lives. And this can lead to some implications in terms of condom negotiation and making decisions in terms of partners, having sex with certain partners and using condoms or not. Many older women experience poor body image or a shrinking level of social power and participating due to aging. There's the WISE study here, and WISE is the Women's Interagency HIV study. And it found that women aged 48 and over reported more difficulty with disclosing their HIV status than their younger counterparts for fear of losing a sexual partner or even the potential option of a partner. So that really says a lot there that, you know, I don't want to say that, you know, I've got HIV because I could lose this potential opportunity here. And so that's also problematic. Okay. So older Black women and sexual risk, there's very little data on sexual risk among Black older women because the focus has really been on younger women for the most part. And that really just speaks again to this idea that older women for some reason are not sexual or are not engaging in sex. And we know that's not right. Older Black women are more likely to engage in sexual risk behaviors than a younger Black woman. And that could be for multiple reasons, whether that goes all the way back to, you know, conversations around sex that we talked about yesterday, that we talked about the day before. Earlier in life, are we having these conversations? Then are we suddenly expected to have these conversations later in life, whether that's through the school system or at home or wherever that might be with a provider? Older Black women view condoms as a method of contraception largely. Postmenopausal women are less likely to use them because they're not worried about having babies at that point. And so who needs them, right? This is, I've heard women saying also like, oh, this is a time when I don't have to worry about that anymore. And so we know that that increases risk as well. Older Black women may have less experience using condoms than their younger counterparts as well. Someone here says, my older Black female clients are freakier than anyone else. They make me blush. I love that. So, okay, so older Black women and sex. So these quotes actually came from one of our panelists was a researcher on this study here. So she may have some time a little later to talk a little bit more about it. But this was a study, a qualitative study that was done at 3 sites, 3 cities. And here are some of the quotes that came from New York City from Black women. So one woman said, and these are women living with HIV in New York. So of course we don't use them, condoms, all the time because he don't believe in his heart that I can pass it on to him. And it hasn't happened in 19 years. So that person was 53 years old from the Bronx. Another one says here, we do unsafe sex. I feel like if you with a partner for a long time and you could trust your partner and talk and your partner's being truthful to you and telling you what he's not out there messing around or whatever, then I feel like you don't have to wear a condom. So that's someone 50 years old in the Bronx. And then lastly here, me and him only use condoms sometimes. We figure out a way where he didn't get none of my vagina juices. We was together 12 years and he never caught anything. And that person was 51 in Brooklyn. And so these are really showing that there is a low sort of perceived susceptibility for a partner, or there's sort of maybe even misconceptions about how transmission happens. And we talked about that the past couple of days within the younger age groups and younger cohorts also had some of these misconceptions around HIV transmission. And so that persists within older women as well. And so we really wanted to point that out. And later when we get with our panel, we'll be able to talk about the perspective of older women living with HIV as well as other older women, other older Black women.
And Hannah, you see in the chat, someone said something about nursing homes, and we have a lot of experience with that, about the rates of STIs possibly higher because what happens in nursing homes. So that's a good point to consider that one of our participants states.
Oh yeah. Yeah, we've done a lot of work in senior centers with directors of senior centers. We were leading a train the trainer program for many years. And we found that it was the people working at the senior centers that were more uncomfortable talking about sex than the seniors themselves. And so there's all this quote that I'll never forget that this woman said when we were in this, I know you know what I'm about to say, Lisa. But there was we did a session, and so one of the directors wanted me to be alongside her as she did her first training with the seniors, and one of the women there said, I may be old, but I ain't cold. And I never forgot that. I just thought that was so funny. But that's right, and that just really speaks to everything we're talking about here. So, okay, all right, so let's move on to the next slide. And I really want to get our panelists on here soon so we can get to the discussion. Okay, so in terms of older Black women and messaging, this is a really important piece here too, because look at these photos that you see in these campaigns. Are these things that you typically see? I don't think that these are so commonly out there, where you see older women in the context of HIV or even sexualized in any sort of way. So here's the age is not a condom, another one of the age is not a condom messages here. And the participant here, actually, Anna was one of our training participants at one point. So she and her boyfriend at the time participated in that. Yeah. And then over here, we've also got the checklist for healthy aging. So if you are doing all these other tests, are you also doing your HIV test? Age doesn't mean that you're not at risk, is the idea here. And so when women don't see, when Black women of this age group do not see women that look like them, much like the other groups that we talked about yesterday, I don't see someone that looks like me, then we get this other message sort of implicitly that this doesn't apply to me, or this is relevant to somebody other than me, but that is not the case. HIV and STI testing, that's right. Okay. So just like yesterday, you'll notice a pattern, those of you that have been with us for a few days now. These are the 5 areas that well, there's one more that should be popping up there, that we identified as priority areas. And these 5 priority areas we want to get to a little bit later on now. So the first one being around the implications of COVID-19. How does COVID affect older Black women specifically? Some of the health promotion and disease prevention needs for older Black women, some of the conversations around sex and sexuality. Are they happening? Are they not? What can we do better? And then the psychosocial challenges within this age group, which may be a little bit different than some of the ones that we talked about over the past couple of days. And then lastly, and most importantly, a path forward. What do we do? What are the recommendations? And how can we improve health outcomes for Black women within this age group? So that is that. I am going to go ahead and introduce our panelists, and we would love to have them join us on their camera whenever they get the chance. So we have with us Dr. Tanya Taylor. Dr. Tanya Taylor is an assistant professor in the College of Medicine and Special Treatment and Research, the STAR program at SUNY Downstate Health Sciences University, a co-investigator in the Multi-Center AIDS Cohort Study, or the MAX study, and the Women's Interagency HIV Study, combined cohort study. Those two are together. And a co-director of the Brooklyn Initiative to Develop Geriatrics Education, BRIDGE, and Geriatric Workforce Enhancement Program. Dr. Taylor has over 20 years of experience in the design and implementation of ethnographic surveys and qualitative research in the US and Southern and Eastern Africa. Her intellectual interests range from medical and linguistic anthropology with a substantive focus on HIV, biosocial aspects of aging, comparative systems of health and healing, health and treatment-seeking behaviors, and sexual and reproductive health. And I also want to add here that Dr. Tanya Taylor has experience in infectious disease as a public health professional and has been working 50 to 60 hours a week since February developing COVID-19 prevention efforts and research. So we really look forward to hearing about that. And then we've got with us as well Michelle Lopez. Michelle Lopez is the Healthy Aging Specialist at GMHC. After working at a federally qualified health center for 19 years, Michelle branched out as a consultant due to her passion for working in public health. This passion continues today, as Michelle says that I live to see this aging in the HIV community, and we must be able to age with dignity. Michelle tested positive in 1990 after the birth of her daughter, and she's making a difference in the lives of her peers every day. And this team, we've worked together for many years, and so we're really happy to come together on an opportunity like this. So thank you both for joining us.
It's a great way to end the three-part series and end the week with the four of us. That's amazing. We've known each other for so many years.
Yes. Okay, so let's begin since time just runs so quickly. Let's go through number one. Okay, so I'm going to pose this question to both of you. So we'll start with Dr. Taylor and then we'll go to Michelle. So the first question is here, how do we characterize or define Black older women? And I know this is a difficult one. And this is the largest age range, 50 and up. How might the needs of a 52-year-old Black woman be different than that of a 72-year-old Black woman? And then how might HIV play a role here? Let's start with Dr. Taylor.
Thank you. I first want to say thank you for this opportunity to talk to Black women about health and sexual health in particular and COVID. I really appreciate being invited here. I was also shocked by the results of the poll. And I just want to remind folks, in human evolution, a 12, 13, 14-year-old at one point was considered an adult, because that's when they could start having babies. And so this evolution in terms of like nailing down, like when does a person become an older adult has really been changing and evolving over time. With, of course, like, development and advancements in healthcare, in access to healthcare. So I want to just say that sort of like older adults, even though there's a lot of inconsistency from the CDC or from like Medicare with 65, that sort of in aging research in the life course, we are in the adult category. And the adult category has three groups: younger, middle, and older. And so Michelle Lopez and I are going to talk to you about older and middle age adults. And there's a huge difference between a 50-year-old Black woman and an 80-year-old woman. And basically, we have very distinct health and psychosocial challenges. But, one thing that sort of captures our big social challenge is the emergence of ageism. And so ageism is defined like as a prejudice or discrimination on the grounds of a person's age. And it's at this time that we start to experience ageism, that we in our society are valued less. We have limited opportunities in terms of jobs, buying houses, insurance. And, of course, this intersects with lookism, right? And the fact that, depending on how you look can also sort of diminish your sense of self and where you are. I'm proudly 52 and entering this phase and been studying aging for a while. And I just want to say that we have different health challenges. And as we age, those health challenges can become more severe. Usually around 50 is when we start to collect what we call comorbid conditions, most common in terms of heart disease and other sort of chronic ailments, or maybe you've been diabetic your whole life, but around 50 is probably when you might need to step up your game. I also want to say one other thing that, and I'm so happy that you did a really thorough introduction around menopause. People don't realize that menopause is an extremely stressful time in a woman's life. And I'm using the word stress for a reason. Our hormones, I mean, it's not just a biological event. It affects our interpersonal relationships, it affects our mood, it affects our brains. And, that stress is, I think, probably one of the biggest concerns for Black women, and managing stress. There's some good stress and there's some bad stress. And I think that, I want to just sort of end with sort of talking about the added stress in terms of COVID, the added stress in terms of the Me Too movement, the added stress in terms of racism, that, Black women have disproportionately been victims and have experienced sexual violence. And I am one of those women as well. And so, we as a group, we have always held on to stress in different ways. Stress of working multiple jobs, because there is also the sexism that, we end up doing more in terms of taking care of others, whether it's our kids, our grandkids, our parents, whomever. We are always saddled with that responsibility. And with COVID-19, that became really complicated. But in addition, there's what we call sort of a daytime hyper arousal, which is basically being woke. And what I mean being woke, it's a social vigilance. We are always, there's an action of monitoring ourselves and our safety around others. And I think that we don't really acknowledge that enough in terms of sort of the threats to women, and that we are just hardwired in terms of this. And so I just want to end with that. Maybe just also say one thing, that elderly is a term that is really only used for the oldest group. It's associated with frailty. So I am not elderly, despite the fact that my kids will think that I'm a dinosaur. But okay, I'm going to try. I realize I forgot some things that, at the age of 50 is often when we have changes in our health and our physical function, whether it's mobility, disability, but we also have changes in our relationship status, from being married to separated, divorced, or widow, and we have social losses. I know it's really hard to talk about that right now in as we are living through this pandemic. But normally, we start to experience deaths. Parents, friends, families, our children moving away, relocating, and this can diminish our support. And, for older women with HIV, which is my primary population, being an older woman, there's also the equal challenge of ageism and HIV stigma, which makes it very hard for my beautiful positive sisters who look fabulous to be able to feel that they can safely disclose their status. All of these stressors are exacerbated by, as Hannah mentioned, these social determinants, poverty, unemployment, housing, food insecurity. But we can't forget racism, sexism, and homophobia.
Yes.
Oh, I'm sorry. There was a one-word answer to that. You characterize older Black women. We are fierce.
Thank you, Tanya.
I should have started off with that. First and foremost, we are amazing, and everybody wants to be us.
That is right. Michelle, do
right.
you have
You're
anything
right.
you want to add?
Oh my gosh, absolutely. I have to. I just thank you all at first for Health HIV. Oh my God, Dr. Hannah, it's wonderful. Just great that, you know, I feel coming full circle being part of this wonderful initiative, you know, that Health HIV here is having, and I'm partnering. So let's get into why Michelle think it was important, or why she needed to say something. I'm in my 30th year of being diagnosed with HIV. I'm 54. And I gotta say, the things that I have learned because of this diagnosis, we women that are aging with HIV, we need to be able for us to have a created standard, because the WISE study, so eloquently told by both Hannah and Dr. Taylor, right? The WISE study has given us some clear information that some women who are living with HIV, we started having menopause in our 30s, right? I have friends of mine, 36. My first year of menopause, I was 49, right? And when I speak to these things, sometimes I'm in a setting where I'm not just speaking because I want to be heard. I'm speaking because I need to educate, you know, women. We have different facets of us out here as Black aging women.
Yeah.
And these are the things that I've learned as someone, an educated consumer is an informed consumer. And I put it to use, not just for me, but the relationships I have with Dr. Taylor. Yes, I even have relationships with people in industry, because we are still not being allowed to participate in clinical trials as Black women, as women aging with HIV.
Yes,
Mhm.
yes.
We saw where Moderna, this company that is going to be doing the vaccine study, they're now allowing people who are HIV positive to be in their vaccine study. I wonder if women is going to get into that study. One like me, yeah. You know, so these are the kind of things I'm going to be talking about. There's a large prevention need. You know, clearly, I lived this experience where I worked on a project for 18 months with a Korea and another company that works with the aging population. Not specific to HIV, but what I surely learned is about the prevention needs that aging Black women need to have, because two things, and we did observe that part of a focus group that we did. Older Black women, from our experience, from my experience, there are methods that they would like to speak about that, if they choose to speak about it. There is a pushback. From my experience, when I went into these nursing homes, these were nursing homes, residential nursing homes, and I was speaking to aging individuals about their sexual health. And the women that came forward, I remember one lady said to me, "Oh, mommy, you did good with the condom." This is a Latina woman. "You did good with the condom demonstration, but you forgot something." I said, "What? Oh my, what did I forget?" She said, "You didn't teach us to put it on with the mouth." She said that to me. You did. A Latina woman was in her 60s. And my African American woman was pretty much, "Oh my goodness, why is she doing that? We don't speak about our sexual." So there's a cultural factor that I saw also too amongst older Black women, that speaks to, you know what, I'm not speaking about my sexual issues, my sexual behavior, my sexual needs to no one in public. I have experienced that. So we got to look at taking that opportunity, because we don't have a standard out there, taking that opportunity, and you get your care that you need patient-centered. We hear the word patient-centered. I'm going to reference it as we go further along. But I needed to say those things. Thank you,
Thank you,
ladies.
Michelle. Lisa, you want to ask the next?
Yes, I sure will. I know Michelle and I have worked together for years, and I know we've worked and done some things around menopause, and we did talk somewhat about menopause. Menopause is such an important topic for this age group, and I know that all of us have worked on when that curriculum was created, and Hannah and I trained this curriculum, and it was really surprising the response we got from Black women on issues of menopause. So with that said, Michelle, what are Black women you're working with reporting about their experience, their overall experience with menopause? Are there any additional to all the things that you shared? Are there other things that Black women are reporting about menopause that seem to be very specific just to them?
Yes, Black women that I am working with, have worked with, done focus group with in so many different facets, because I love having conversations, have shared with me they feel very unheard. They feel very unheard to the extent where they're not even being allowed to express. Sometimes as a person, in order to be heard, you got to go into details, and they're not getting this opportunity to speak even. I think a part of it with their ID doctors, their HIV care doctors. But I also, to some of us, I can tell you here in New York, we have, where I get my care, I have a wonderful gynecologist, and she really has been addressing my sexual health and my care throughout the years. I identify as a bisexual woman, so guess what? She's on point. We have had that discussion. And so she knows, Michelle, so who are you having sex with right now? We had a conversation. COVID is going on. Did I have my needs? Yes, I did. We have our needs, and a lot of us, we feel embarrassed. I had some wonderful sexual experiences, but nobody touched my body. No, it was called show and tell. We know about FaceTime. We know these are the things that I speak to women about, and I say, give it a try. Use that FaceTime. Yes, indeed. Show them. After COVID, these are the things, oh, honey, I spiced it up. So I had, my needs covered while COVID is going on, because I did my social distancing. Oh, yes. But I can't tell you. So when I saw my gynecologist, I said, girl, I discovered something and I'm doing it. We had a conversation. So, and she asked me, so who you did the show and tell with? I said, with everyone. Who asked? Who asked? I had to give it a try. I have to test out things. I have to test out things to see if it's going to work. And I did, so these are the things that keeps me going. These are the things as aging women, older women, menopause, what it's doing to us. Some of us really feel as if we have lost our minds. And I'm going to use the word, it makes you feel like you're crazy. I'm not crazy, no, but I spoke to the other person about this. I told my HIV doctor, I said, listen, the way I'm feeling, I said, there are some days, I talked about it. Conversations with every one of my clinicians is helping me. I even shared it with my endocrinologist. I'm a diabetic woman, so there's so many other factors that's going on. And here comes menopause, and that's thrown into it. And as Dr. Taylor talked about these hormones and what's going on with our bodies, we need to be heard, and we need to be able to express and give the details of really what we're going on, what we're feeling. And then we can talk about my treatment plan. Not as soon as I give you one sentence, you start writing a script. Yeah.
So, Dr. Taylor, you want to pick up on that?
I do, and also sort of link back to some work that my nickname for Michelle Lopez, who is like, I'm her biggest fan on the planet. She is my most valued colleague, and she and I developed an intervention for older women with HIV. And we used in this intervention as a hook to talk about healthy aging, is to create a place to talk about menopause. And the women loved it. That was what they wanted to talk about. And the social group that's connected to it in terms of having a space, because it's not happening with primary care doctors. They're not having that comment. For them, it's just a biologic event. It's not, it has no other impact. They think about the vasomotor symptoms, which is like the hot flash, and that's it. They don't understand how it's really impacting our lives. And so I was really proud to work and develop this intervention with, but I wanted to also add that, we really discovered that older women don't know a lot about their bodies. And, I'm sure in the previous conversations across the life course with the younger and the middle-aged folks, that this is a recurring theme. And then when you get to be 50 years old and you don't know where your stuff is and you don't know what's going on down there and you don't understand your body. You just feel like I've just had my period. You don't understand what is happening when you have your men's in terms of the hormones and the fluctuations, and you don't understand these changes. And maybe you have positive nurturing women in your life who are able to guide you and sort of say, this is what it was like for me. But you know, a lot of us don't have that. And so it's kind of a mystery. And so we live in shame, we isolate, we say it's all over. And you know, Michelle and I are so super pro sex and you know, and pleasure positive approaches. And you know, it was a very interesting experience to realize how little people know, or excuse me, women know about their bodies, about menopause, what's happening to it, to them, and the other sort of really harmful effects. Like, for example, insomnia. Insomnia is one of the most common symptoms of menopause. I had terrible insomnia before I was perimenopausal, which was only exacerbated by my menopause. And I want to say this to everyone. I know everyone sort of says, sleep's not, you know, I can function on 6 hours of sleep. Yeah, keep doing that, because as we do that, we are doing harm to our brains long term. There is a huge association with limited amount of sleep and Alzheimer's and dementia. And so this is the moment in our lives for us to actually really start thinking about sleep health. I'm about to start a study on women who are positive, who are menopausal, through the perimenopausal, and insomnia. Because sleep, whether you're positive or negative, this is the key to health and well-being, and not enough people are talking about it.
I just wanted to quickly mention some of these comments.
I'm sitting watching them.
Catches up to you.
Yes.
Insomnia is so real, so true.
Yes.
And there were so many comments about Michelle. Yes, Michelle Lopez's goals. Yes, let me transparency is life, and yeah. So people are. Really
I love this, Hannah. Yes, living your best life.
Exactly.
We don't have to suffer through with insomnia, and that's the thing. And as we get older, like a little story, you know, I'm really blessed to have known all of my grandparents and two great grandparents. And my grandfather was 23 years older than my grandma. I remember coming home, I was a bartender at 3, 4 o'clock at night. My grandfather would be up and he would not understand what was going on because he had messed up. He would sleep all day and he'd be up all night. And, you know, and there was no thought to trying to address this. There's a huge part of medicine called sleep medicine. There are interventions. We can work on our sleep hygiene in terms of developing things that can help us get back to a good, healthy sleep level. And trust me, sleep is so key. It's basically undoing all of the ickiness of the stress that we live with every day. And so we have to sleep, women. We gotta sleep. We have to take time for ourselves. No daytime napping. Sleep. Turn off your phones. Stop listening to the news and stupid Donald Trump. You need to have at least 30 minutes. No, really. We have too much screen time. And we go from screen time right into the bed. And we are overstimulated by this. And so what we need to do is we need to develop self-care rituals at the end of the night. Get a book, read some affirmations, do something that is meditative, quiet. And, you know, I mean, I can talk forever about sleep, but it's really important. We can fix it, bottom line. You can fix your sleep.
Tanya, thank you for that. I think that is such an important point that people need to walk away with. So thank you for that. And as someone said, thank you. Preach.
Yes, so true. Yes, very true. Everyone is agreeing with you.
Everyone's agreeing.
So I want to shift gears a little bit, though, and get back to COVID, which is something that we kind of briefly touched on a little bit. But this is directed to Dr. Taylor. How has COVID really impacted Black women within this age group, and what have been the implications of that?
Oh, yeah. So look, you know, COVID-19, as it has proven to all of us, is not just a medical issue. It is profoundly, it is economic, it is, you know, it is political, it's, you know, psychosocial. I mean, this is really, really, really hurting our older women. I just want to sort of say, and I won't bore you with the prevention, although please wear a mask and stop doing these like speakeasy parties and hanging out. This is, most people get COVID-19 because of something called asymptomatic spread. Please, we are going to have a second wave in the fall. It is going to be worse than the first wave, and it's going to overlap with the flu season. Wear a mask, get a flu shot, please. But the thing is that, you know, we all know that at the beginning of the pandemic that older adults were thought to be the most, and the 8 out of 10 deaths, COVID deaths in this country have been over 65 and older. And we know that, you know, the increased risk of severe illness in terms of cancer, chronic kidney disease, COPD, immune compromise, whether it's from HIV to cancer to blood or bone marrow, organ transplants, obesity, and heart condition. What we have also learned, there are a number of other things that might, you know, like asthma. I have severe asthma. But one thing that we've learned in terms of our research at Downstate is that hypertension was one of the key comorbidity driving, I mean, or associated with the deaths. Hypertension, obesity, and poorly managed diabetes. So in this particular shutdown moment, it's been really hard for people to navigate healthcare that is now virtual. Telehealth, what the frick is that? Telemedicine, telemonitoring. It's a whole new vocabulary that we need to learn. And the truth is, a lot of us don't have the e-literacy or the technology proficiency to be able to like download this app and be able to do a virtual doctor's appointment. And we're not even talking about the people who are poorly linked to care that don't have even that option whatsoever. There's no free, you don't have insurance, you know, virtual doctor's appointments that I know of. Maybe somebody else does. But you know, it is also really impacting us in the fact that sort of as women, we're doing double duty. Okay, you know, it's again clinical, economic, psychosocial, access issues. We have a higher burden of known risk factors. We have limited access to care, especially with this telehealth. We have the burden of child care and caring for others. Most of us didn't know anything about teaching, and all of a sudden we've got a whole bunch of kids at home and have to actually sort of navigate this virtual remote learning. We've lost our jobs, and for single mothers that has been devastating. Essential workers, most of the essential workers in this country are Black and brown people, and guess what? A lot of them are women, nurses, janitors, you know, at my facility. And we've lost so many people at SUNY Downstate. We lost our head nurse who was there for 25 years. We lost this really wonderful woman who used to clean on the main floor. I'm devastated. I've lost 3 friends. I've lost 5 neighbors. And you know, most our white cohorts are not having this experience where they have so much loss around COVID. And this is having a profound also impact on our communities and our mental health. You know, we have this vigilance in terms of like, you know, trying to protect ourselves from COVID and protect ourselves from this racism. And I'm so happy that Michelle Obama in her podcast the other day said, you know, and admitted that she's had, that she has mild depression. I feel like I have had mild depression, but not mild. I feel like I've been suffering from post-traumatic trauma for about 9 years since the emergence of the Black Lives Matter. And it's only gotten worse with this president. And, you know, it's all having a toll on us. I remember during the protests and the fireworks and just thinking that, like, it sounds like we're in a war zone, and it was making me crazy. I was so scared for our young people that I'm so proud of, but I just couldn't help but to think that that was also a strategy to hurt Black people, to make us be off ease, not have our sleep during this critical moment. Anyway, I just, you know, and look, the solution is self-care. We have to put ourselves first. You know that when you get on the airplane, if the plane's going down, you put the oxygen mask on yourself and then you take care of your children. We never do that. We always put other people before ourselves. We always do. I grew up with a grandma who was like the epitome of that. And you know what? I didn't learn my lesson. I still do it. Everyone else gets fed and out of the house, and I still haven't eaten or taken care of myself. And we need to put ourselves first, because guess what? If we go down, our families go down. And so it is, we are the stressed out folks. And that's why I said in the beginning, stress is the killer. Stress kills people. It exacerbates your cardiovascular disease, hypertension, whatever. These can create stress. I mean, it's a killer. It's a killer. So we need to get into mindfulness. We need to get in our prayer and meditation. We need to do this, because right now is the most stressful time in our lives.
Yes, yes. Thank you.
I could talk forever about COVID-19.
No,
but,
that is, I mean, what you said,
that's what I think.
it's just so relevant and so timely, and we appreciate all that you said. It was, I mean, I have kind of like goosebumps right now, seriously. But it was. So we're gonna pose 2 more questions, and we want to get time for our panelists not our panelists, our participants actually ask some questions. We're gonna go with 2 more questions. This question's for the lovely Michelle Lopez. Michelle, can you speak to the significance of language here and how to approach the conversation on sex and sexuality with our older Black women? Unmute yourself, Michelle.
And Mimi, also add ageism into that, the ageist language.
You know I am. Oh my gosh, Lisa, thank you so much. Sorry about that, folks. I can say, and I am going to start off first, you know, just looking at the impact of ageism. And if some of us is not even realizing this is what we are experiencing. So if you don't even realize it's happening to you, you know, how can you even address it, you know? But I call it as I see it. Throughout whatever system we're navigating, it's like either you really have to be your own advocate. I can sit here and I can give, you know, multiple examples. I can give case scenarios of situation that I witnessed and also too that I experienced. I am navigating the healthcare system, and as I age, based on facts that I am aware of because I have read this information, there are certain requests and tests that I ask my doctor, and she looks at me and she says, so why do you need that? And I give her the reason why, because I can reference these different, you know, publications that we have out there. Those of us, again, I keep saying it, an educated consumer. And I'm not speaking, no pun intended, I love the letters behind my colleague's name, but sometimes because of literacy issue, you know, my work with Lisa will forever be treasured because I talked about learning the importance. Health literacy is a large component to some of our deficiency. You know, I do teach backs. When my doctor said, look, okay, I'm ordering this test for you, I'm ordering, and same thing I do with her. Please explain to me why you're ordering that test, even before I go for it. Because once I get that information, I know how important it is that I get to either that referral or that appointment. So at times, you know, when I said I'm going to start off talking about ageism, right, there are some of our needs are really, it's not being carried out, but we are not aware of what it is, some of our, clinical aspect. And this is why I keep using the word. We need to have develop a standard of care when it comes to us aging Black women. Right? I'm not being biased. As I said, I can really speak to the prevention needs of an aging woman that's negative, right? Because has been my history of work. But as a woman that's aging who is positive, there is so many deficiencies, health inequities that we're experiencing and we're not even aware. And these are the things that do impact the outcomes of our care, the outcomes of our livelihood. I was sharing it yesterday. I shared this with a group of individuals. We're working on a wonderful project now through the New York State AIDS Institute, the aging population with HIV. And based on the things, and I'm saying, listen, we should recommend this. People are like, well, Michelle, we need to do the survey. No, we don't. We don't have to do that survey. Dr. Stephen Kirkpatrick, Dr. Tanya Taylor, she's up at Einstein. I could name the doctors and the CFAR that we have up at Einstein in the Bronx. These are all the research that's been done, with us throughout the year. So that information is there. We should not be, yes, there's values to surveying, but the value, I think the focus group is what they need because it's time to act now.
Yeah.
Can I recommendation for us aging folks? Again, those of us aging with HIV, and we need to be able to have that incorporated into our care.
So sorry I interrupted you, Mimi. I was
Michelle.
Feeling your energy, but I wanted. I'm a linguistic anthropologist, which means I focus on language. And to me, ageism is mostly through language. How people are talking to us, dismissing us. Older sexual women, we're invisible.
Oh, wow.
Oh, wow. We had some.
Oh.
Maybe 30 something and under. I'm just like, where's the stuff for the older folks? That invisibility. No, that said something. I never went back to that conference again. I was just like, never mind. But the truth is, it's in language. It's how people talk about us as sexual beings. No, you're too old for that. That's ageism. Also, in the representation. The intervention that Michelle and I developed, we couldn't find any videos of some Black folks getting busy. It was like impossible. Instead it was like, let's hold hands walking down the beach. No, see them in the bed getting busy. And we found this one ad, which I'm so happy I downloaded and I have it forever. It was a Red Bull ad. Remember that, Mimi? With this Black sister and this who knows, maybe he's a person of color. And they were like, the room was full of Red Bull cans and they were having fun. But those images don't exist. They don't. And there was a moment in Hollywood when they were trying to address this, but it's only been with white people. Like, we are not, as Black women, older Black women, and think about this, media representation of older Black women, how many of us get to have sexual lives, be sexual? Angela Bassett is always like, being, charged, a top-notch, whatever it is. But how many roles does she get to really show her as being a sexual woman as an older woman?
It's an older Black woman.
Right.
Yeah. Well, there's a lot of
stigma.
So well.
There's a lot of stigma also too, and stigma, I'm going to call it as I see it. We have the internal stigma that us aging Black women are dealing with, and we have, stigma out there from society, or, it is not up to society to dictate how I live my life. No, I create my own joys. At this age, I am not looking for someone to make me happy. Oh, no, I know what I can do. Yeah, when I want more fun, I'm gonna add somebody in there, but I know how to keep me happy and be happy. I've dealt with, a serious amount of trauma. Some of you I've shared with, within the past couple of months, but guess what, honey? It's a good day today.
Yeah, Michelle, that's a really important point because, at this age, we need to know what makes us happy. And sometimes you learn that. And some things
Yes.
do come through the years. So through our lifespan, by this age, we know what makes us happy. So Michelle, thank you for that.
Actually, that was one of our findings, was that the older women are just like, I don't need, I know what I know. It's like, finally, I figured this out. And women, older women, like, we were like, we got it now. We got rid of all that baggage from trauma and abuse. We've worked it out. And now we're just like, it's our time, especially being postmenopausal. And I just want to also sort of say
even more
that,
self-assured.
I need to just say this because I am an HIV researcher, that a lot of people think that just because you're postmenopausal and your partner's just like, well, you can't get pregnant, and he will sort of discourage you from continuing to use condoms. Let me just say that according to the CDC, is it like 16% of new HIV infections are among folks over the age of 50. And with women, 87% of that is through heterosexual contact, okay? And this is not also, these conversations are not happening with the providers, because honestly, these young doctors are just need some help, because they're like, oh, they look like my grandma, I can't talk about sex. Get over it. That is your job. And they're not having conversations about sex, sexuality, sexual health, and we need to address this.
Listen, this is a great conversation. I love it, love it, love it. We're going to go to some questions. We want our participants to be able to ask some of these great questions. So, Hannah, you have any last words before we go to our Q&A for Tanya?
Let's go ahead and go into it, because there's so many questions here. So we really want to
get it going.
So we can open the lines for some questions. So there's one here around U equals U in PrEP. And so I wanted to open the lines to Uju Nwizu. Hopefully I'm pronouncing your name correctly. You could join us and ask your question. That would be great. You can unmute. Yep.
Can you hear me?
Yes, we can.
Yes, we can.
Hi. Oh my gosh, I didn't know I'd be talking. So much. This has been so awesome to listen to you, Michelle and Dr. Taylor. I was wondering, as you were speaking, with the women that you worked with, and this, I guess, for everyone on the panel, like, do you find that they are aware of U equals U and PrEP, especially looking at the statements you were saying from some of the women that you talk to? Because I feel like as a PrEP navigator, a lot of our conversations around prevention can be very barrier focused, which is great, especially knowing that PrEP and U equals U is mostly like, is related to HIV, but I'm wondering, like, are those on the tips of folks' tongues? Like, do they know about those other prevention strategies?
Two things I have to say again, because of my work that I did for that 18-month project I spoke about with Akria, and Live On New York. That's an organization that provides social services support for the elderly, for the aging population. And what I did say, there was a major lack amongst the African-American older individual at these nursing homes and residential programs. These are programs called NORCs, the Naturally Occurring Retirement Centers or facilities, and they are all through New York. And I have to say, so I literally had to break it down for them. And when I explained to them what I can say, clearly from the audience was back to me, why aren't doctors telling us older folks about PrEP? Okay, so again, I had to address the issue of becoming your own advocate. Everyone had pamphlets who wanted to know more about it. I said, this is a conversation starter. So sometimes we gotta, provide the resource to the individuals, let them know what's available there, and then give them that opportunity for them to take it to their doctors and start the conversation themselves. That's where I see, where, becoming your own advocate, it was so enlightening when I went back, because I'm a person, I do not do one-shot deals. So I went back to this, facility, and there was some things who took it to their doctors. Their doctors said to them, why you need that? Hello, I'm telling you something. If I have interest in PrEP, there's something I understood here. PrEP is a treatment that can prevent me from getting HIV. I'm telling you something. I'm having sex. right? So, I see it where at times, we focus a lot. Yes, I would love for the CEIs program that we have out there, to be able to engage some clinicians when they come in, to let them know, especially primary care doctors, the importance of informing and educating an older adult about PrEP. Let them know what's available, build a mountain, and yes, they will come. It's not for you to make that decision. Oh, no, I have some information that I'm providing all of my, aging elderly folks, because I remember last month I had to do a treatment for you for chlamydia. So I know you're having sex. Normalize it. Normalize it. Normalize. We've heard the word as consumers, make it part of the routine care. No, I'm telling you as a consumer, let these doctors know. You can normalize the conversation with me. It's a normal conversation. As someone said, as Dr. Taylor said, cut it out. It's part of your job. You're here as a medical provider, providing care, nothing else.
Can I chime in?
Yes.
I want to say that we've been waiting for over 30 years there to be a prevention method for women, exclusively for women, where we don't have to negotiate condom use with a partner, okay? And finally, we have something that we can take, and we don't need to tell anybody about it, that can protect us from getting HIV. And what is infuriating me, and Michelle knows this and others, is that it has never, ever been marketed to older women. And I find that just despicable. It pisses me off. And I will continue to try to work with my colleagues to understand that it's their ageist assumptions, and that they need to be talking about sexual health. And older women, again, remember I told you at the beginning, characterizing our age group, around 50 is often when relationships break up. So you have a whole bunch of fabulous 50 women who are back out on the dating scene, okay? And they're not thinking about STIs. And the fact that STIs, sexually transmitted infections among 45 to 65-year-olds has doubled and tripled, okay? Because it's a generational cohort thing, and I get it, but we need to be doing a better job.
Thank you.
Thank you.
So there are some other questions here that I want to try to get to as well in this limited time. Another person has asked this question anonymously, so we won't open the line. I'll just read it. It says, how do we have these conversations with older Black women in a faith-based setting? Or what is the role of faith leaders in this conversation? I don't know who wants to.
Are we not allowed to talk about sex in the church? I mean, no. I think that I mean,
there is a knife. Tanya, there's colleagues of mine who does faith-based initiatives. And one of the things that I knew that they did, they would have a themed Bible night, right? So healthiness, healthcare, healthiness is also two-part. They aligned it, again, with their biblical teachings. And I was brought in, and I said, the reason why I was brought here, they let me, pretty much speak to the women. They brought me in as a speaker. That's how some of the ways, or again, if a pastor, a reverend of a church is courageous enough, it has been done. I have heard it has been done. I did not witness it, but they can dedicate, one of their sermons, yes, indeed, referencing, talking about working with, with the sick, with the elder, align it. You align it with what, the culture of your church domain. But there are Black churches that are doing similar initiatives. But
yeah, there's a lot of comments coming in, Michelle, about sex as a taboo.
Yeah, look, I hope my comment didn't turn people off. But look, faith, the churches have been talking about sex, talking about abstinence with young girls, or it has been happening in church. I know it, and it continues, especially with younger women, in terms of talking about abstinence as a choice. Okay, so
well, we're not speaking about abstinence.
No,
We're
not with us,
talking
but I'm
about,
just sort of saying, I'm just saying sort of the church is a possible site. And the thing is that, you know, as we get older, there, you know, again, this invisibility, which is, you know, a part of ageism. There's no attention to our sexual health needs as we go through the life course. And so I think that sort of faith-based organizations are on it with the younger folks, the adolescents, but then over time, there's no real consideration about sort of what's happening as being young mothers, older mothers, grandmothers, you know, promoting like sort of, you
Tanya,
know,
the women got to
women's
build it
health, like,
themselves.
you know, breast cancer, pardon?
They got to build it themselves. There are women who have gotten together, who have sat with the, you know, administrators, you know, of the church, because remember now, churches, you know, their structure,
I
again, no
agree with
pun
you, Mimi.
intended,
Yeah,
but
I agree.
they sat with the reverend and said, we would like to, you know, to do this. So, you know, it's also to, you know, season, you know, to get that, to pull that, you know, for you, get together. We are powerful in numbers. 3 or 4 women approaching the church. Sometimes you would not find the church being progressive in that aspect of it, right?
Yeah.
So let's be real. You know,
Yeah.
we're not
This is a
pointing
big
fingers,
issue,
but
especially
it's
in
a
Black
reality.
communities. Yeah,
Yeah.
this is a big issue,
It
especially
can
for
be
Black.
done. There just has to be the
But
will.
yes, it can be done. Yes,
It
it can be done.
be done. Yes. Yeah. But it's going to take, again, us coming together, forming
Yeah.
a nice little path.
So I'm seeing
Yep.
some people saying that, you know, some churches are open to having these kind of conversations now. Going into churches involves respecting their beliefs, but also educating
Right.
them. And sometimes it's about finding that gatekeeper, that person that's
Yes.
open to that and getting you kind of in the door. So that Michelle can go
Yeah.
there and have that
Oh,
conversation.
Yeah.
yes,
Yeah,
honey.
we
That's when
can.
Lola comes out. Yes, my older gal, her name is Lola.
Okay. All right.
Lola,
Michelle.
Let me try to get one more in here. And this one comes from, actually, there are a couple of other questions maybe that are directed to you, Tanya. Maybe you could just address them later on. But this one is from Yvette Hewitt. Maybe we can open the line for Yvette Hewitt. And it's about health outcomes and providers, minority providers.
Mm.
There she is. Okay.
Hello
Okay.
again.
Yes.
Hi,
David.
That's first and foremost absolutely fabulous, and thank you for the whole series and all the panelists. Out here in Minneapolis, we've been at the forefront here for the last couple months, but prior to all of the drama that's been going on, it's still a white state, and so the lack of minority providers out here is detrimental. So for those of us, this conversation has been enlightening, but you're both primarily in areas where there's a large minority populations. What do you suggest for patients who are looking for providers of color, and what are their options? Because out here, and there's a lot of other areas, rural areas where women are here, there is no options.
especially within Planned Parenthood. It breaks my heart, you know, that there are so few places for women across the life course to get help, to go to a, you know, maybe it's not a person of color, but maybe it could be a woman at least, you know, especially around sexual health. I don't know really how to answer that. And, you know, I think that sort of I know a lot of really top-notch doctors and doctors of color that have made that commitment to go out to the Midwest, to go out to sort of rural America. And I think that that's really important. I might not want to live in Kansas, but I understand that they want to be of service. You know, I mean, it seems like your question is really kind of about like sort of like developing more doctors of color. And, you know, there's racism in terms of, you know, applications. And I've seen it in my own institution. I'm faculty in the College of Medicine, and I've seen the diversity go down, down, down. Our president of our institution paid for a Black man's full medical school with his own money because there are not enough male, Black male doctors. The truth is there are far more Black female doctors than Black male doctors, but they're not, for reasons that make me sad, are not going out to areas. But I just want to let you know that, like, I'm working on this geriatric aging program, and we're trying to actually develop, we've developed a method where we're able to provide support, especially in terms of clinical support, whether it's around dementia, Alzheimer's, the whole aging process, geriatric syndromes, where we're doing it using Zoom. And the program's called ECHO. And what we're trying to do is that it was set up years and years ago to be able to let physicians, especially physicians of color, be able to reach out to communities where they might not have the expertise available. And so I think that that might be a solution to sort of figure out, especially now that we're in the Zoom era. I hate Zoom. That, you know, to be able to bring in and have at least an opportunity for patients and providers to learn from our doctors, men and women.
Thank you.
Did I answer your question, Yvette? I hope I did.
And someone did put in, maybe there's a telehealth option with a therapist that has reciprocity with the state like Minnesota. So telehealth options, like you were talking about, Tanya, are, you know.
Yeah, but you know what? There's so few Black therapists. And I know this because I had to try to seek some mental health support for my son who was not doing well with COVID. And it's like, that's when I realized the huge disparity. There are not enough Black people in general, whether male or female, in the mental health, like in terms of psychology, clinical psychology, psychiatry. And that pains me because I want all my doctors to be Black. My primary care doctor is a Black woman.
Well, listen.
I sought her out because I know that this is really important, because we know about health disparities and the fact that so often they don't listen. White doctors do not listen to Black people when they are presenting with issues. Oh, they're just trying to seek some pain medication, or oh, this, or they diminish it or whatever. And, you know, I made that choice to have a Black doctor because I didn't want a doctor questioning my, you know, my need for help. And she's been extremely responsive.
Dr. Taylor, thank you so much. We have definitely run out of time. Dr. Taylor, Michelle Lopez, you ladies brought it today. I am so excited. We have to finish up. We have to finish up with the slides. So we're going to go back to our slide set and end for today. What a terrific series. I am so proud to have been a part of this. Again, this is just another slide on reiteration of how to actually claim your credits. So please do that. And we will. So, and I just want to finish up with our Synchronicity conference, and this conversation is going to continue in our Sync 2020 virtual conference. We're going to have so many great presentations about women and Black women and health disparities and PrEP. So please visit us and please join us for our Sync 2020. We are going to have, these are the 60 sessions, institute tracks, some really great speakers there. I think you guys will enjoy this. Again, we will be offering credits, free credits through our Synchronicity conference. And these are some of our 5 plenary sessions. Michelle Lopez is actually part of one of those great sessions. So you will actually get the chance to hear the great Ms. Lopez again. And these are our 13 tracks. Very, you know, just diverse information. Our 7 institutes, especially women's health and generational health. Those are my tracks, so definitely come and see those. And actually, this is going to be a really special section, intersectional stigma and access to care. Great conversation. Please, you guys need to tune into this. And last, such great, our Black Women's Health Institute. And that's going to be the first day of the conference, 2 to 4. Some really great conversations that will continue there. And the women's health track sessions on epidemics, engaging women in HIV care, and addressing disparities around women to end the epidemic. And for more information on technical assistance, Hannah, Tessima, thank you, friend and colleague. Dr. Taylor, Michelle, love you ladies. Thank you guys. We had a great series. Thank everybody for attending. And everybody have a great weekend and stay safe. Thank you very much.
Thank you all.
Thank you guys.